COVID-19 clinical rounds. This one's on critical care and update on the effects of COVID-19 on pediatric aged patients. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations and societies who have collaborated on these rounds. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays critical care, and Thursdays are emergency department. This Thursdays will be on how the pandemic changed crisis standards of care. Next week will be a bit different. We'll replace the usual series of 3 rounds with another interdisciplinary COVID-19 clinical grand rounds next Monday, May 24th. This grand rounds will be in follow-up to polling responses from our recent grand rounds, and will address the question, why are so many hospitals and EMS organizations unprepared for another surge? Again, next week, grand rounds will be on Monday, May 24th, replacing the usual series of 3. I'll now turn this over to Dr. Bruce Strumminger with Project ECHO.
Thank you, Rick, and welcome everyone. Thanks again for taking time out of your super busy schedules to join us for what will be, I know, a great discussion and presentations today. Just to review some of the logistics, we really appreciate your questions and comments, so please share those in the Q&A feature at the bottom right of the Zoom toolbar. We'll try to get to as many of your questions as we can. If you have any technical or logistic issues, please share those in the chat and we'll try to help you out and solve those, any challenges. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. Today's presentations will be shared along with the recording on our website that supports the clinical round series. And I'm sure Samantha is sharing a link to that right now, and the materials will be available within a couple of days. Also, we are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll share a link to the CME survey, which should just take 2 to 3 minutes to complete. We really appreciate your feedback. It helps guide us with planning. And so please take advantage of that opportunity. It's also, you can find the link on the announcement that went out today, and you've got 48 hours to complete the survey and receive the instant CME. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Please, let's continue to keep them apolitical and non-commercial. Thank you for that. Just a note about data use. We take data stewardship very seriously, and your individual data is all kept confidential. The data we do share with Rick and Asper is all de-identified. Rick mentioned that NETEC is a partner in this clinical round series. They have their own terrific webinar series as well, and we'll share a link to that in the chat. They have a session coming up this Friday on long COVID syndrome. and they have their whole archive of prior recordings available as well. So we recommend that to you. Also, just want to remind people about the CDC, IDSA, Infectious Disease Society of America. They have a real-time learning network, and every Saturday they have a clinician call. Last week, actually, it was on COVID-19 vaccines for adolescents. All of those programs are recorded and available, and we'll share a link to their site. I just checked their website and they haven't announced the topic for this Saturday, but if you sign up, you'll get those announcements. So with that, Rick, back to you for the crowdsourcing question for today, or to Jeff.
Yeah, thanks, Bruce. I'll turn it over to Jeff in a second. You're all reading the crowdsourcing question right along with me. What concerns you most about identifying and or caring for pediatric COVID-19 patients? While you're thinking about your responses to that, I just want to make a really brief comment. Like you, I listened to Dr. Strominger talk about how, or the request to keep these rounds apolitical. I've heard him say that way over 100 times, I think, for these rounds. And while you hear it, I hear it, I cannot tell you how amazing it has been over now close to 160 rounds, where with one very minor exception, you clinicians have kept these apolitical, and that's a testimony to clinicians staying focused on patients. And just a big, grateful thank you. That's its own story in and of itself. Got to write that one up too, Bruce. Anyway, over to you, Jeff. And Dr. Dichter has been an extraordinary contributor to our rounds in coordinating the critical care sessions over the past weeks. And big shout out to him as well. Thanks, Jeff.
Thank you, Rick, and thank you, Bruce. Good morning, everybody. Good afternoon to those on the East Coast and in Europe. It's welcome to have everybody. I was really excited and am really excited about our session today. We have Brad Goldberg from the University of Southern California and Children's Hospital in Los Angeles. And we have Dr. Anna Lin from Stanford University and their children's services as well, to talk about the effects of COVID-19 on pediatric age patients. Both of them come through us from one of their professional organizations, RAPM, and I'm excited to hear them share a little bit about that as well. Anna, we'll go ahead and start with you if that's okay, and I'll turn it over to you and go ahead.
Can everyone see my screen?
Perfect.
Thank you, Dr. Dichter and Dr. Hunt and Dr. Strominger for inviting us here to talk to you at Project ECHO Critical Care Clinical Rounds. Brad J. Fisher, Dr. Anderson as well, and myself are part of this group called the Western Regional Alliance for Pediatric Emergency Management. We are actually an ASPR-funded awardee as a pediatric center, pediatric disaster center of excellence. So we do want to make sure that we're disclosing that. It's this group has been really phenomenal over the course of the past year, pulling together pediatric experts who are interested in emergency management from 6 different states, including Arizona, California, Nevada, Oregon, Washington, and Utah. And amongst the speakers, you have 3 from California, 1 from Nevada today, and 1 from, well, I think that's it, 3 from California and 1 from Nevada. Today we have 3 objectives. I don't think that we'll get to the last objective given that we have a very short time frame, but we will be reviewing the epidemiologic impacts of COVID-19 in the pediatric population. And then we do want to discuss acute setting critical care considerations for MISC or multi-system inflammatory syndrome in children. And if we have time, we'll go over evolving mental health emergencies during the COVID-19 pandemic. As with everything, we start out with a little bit of epidemiological data. People are probably very familiar with this website from Johns Hopkins. We have seen over 162 million cases of COVID worldwide, with over 3 million deaths now. If we look at children, and this data is compiled from Children's Hospital Association and the American Academy of Pediatric, of the 27 million patients that have had COVID, almost 3.8 million are actually children. And what you'll see in this graph is that the proportion of children is actually growing. We started out at less than 3% and now are at about over 20%. Luckily, as opposed to our adult colleagues, the impact on children is actually a little bit less. We only see a hospitalization rate of 2 to 3%, and we've seen about 306 deaths, pediatric deaths associated with COVID. This is actually quite a bit when you compare it to other infectious disease outbreaks. I'm going to turn it now over to Dr. Goldberg, who will discuss the case.
Hi, good morning, everyone. And once again, thanks for having us with you today. So we'll kind of jump right into it. We figured we would start with a case on MIS-C, given the critical care nature of the talk today. And this is probably one of the aspects of COVID-19 in kids that most often leads to a critical care admission. So the case is a 13-year-old female who presented to the emergency department with a history of tactile fevers. There was no thermometer at home, so it was never measured, for 4 days. And I will say, often we kind of poo-poo when parents tell us it was a tactile temperature, but parents are actually pretty good at determining when their kids feel warm. So I tend to take that seriously if that's a part of the history. She had complaints of headache, sore throat, abdominal pain, and the day of presentation to the emergency department had about 7 or 8 episodes of non-bilious, non-bloody emesis. There was no recent illness, and in this case, there was no history of a known COVID-19 infection. Her histories were significant for a history of leukemia, but she had been off therapy and remission for about 8 years. So here's her initial set of vitals. She was febrile, 38.4. So yes, the parent was accurate in that she was probably having fevers. Heart rate was 164, which is very tachycardic for a 13-year-old. Respiratory rate was 24. Blood pressure was 95/56 and was satting normal on room air, 99%. So some highlights from the physical exam. This patient was very uncomfortable appearing, and most would describe her as ill appearing. Her head and neck exam was notable for a rash to her neck, complaining of right lateral neck pain, had very red injected eyes and dry lips. Abdominal exam was diffuse abdominal pain, not guarding, not distended, but just tender throughout. And her cardiovascular exam was notable for the tachycardia. She was warm to touch on her extremities and had brisk capillary refill. So in kind of formulating an initial differential for this patient, the things that come to mind are sepsis, toxic shock, deep space neck infections with this weird lateral neck pain and rash she was having. There was thoughts, could it be Lemire's disease, although that's pretty rare. Kawasaki is one consideration with the red injected eyes, the fevers, ill appearing. However, it's a little bit atypical for a patient of this age. We also thought about abdominal emergencies such as a perforated appendicitis, and then kind of in our back pocket, other entities such as rickettsial diseases, although the rash she had was not typical, salmonella. But in the era of COVID-19, for most of these patients, MIS-C is in the lead differential with sepsis and toxic shock. So abbreviated summary of some of the labs that came in the first couple of hours. Her white blood cell count was about 29,000. H and H, hemoglobin, hematocrit were normal. platelets were 156,000, and the differential had 87% neutrophils, 10% bands. Her inflammatory markers were quite impressive. Her CRP, not CPR, her CRP was 33, an ESR of 76, and she had a significant acute kidney injury on her chemistries. Her initial VBG, you can see there, was actually looked okay. Her pH was 7.34, PCO2 of 39, and a calculated bicarbonate of 21. The lactate was normal initially, but that did change. Some secondary labs, because we were considering MISC, and we can talk about this more if we have time. Her BNP was very abnormal at 955. It eventually peaked at about greater than 5,000 during the hospital stay. And she did have a small troponin leak on her cardiac biomarkers. Later in the hospital course, it was determined that her SARS-CoV-2 IgG titer was positive. So despite not having a history of a known COVID-19 infection, she had a high titer for the IgG in her blood, and her blood cultures were ultimately negative. So in our initial management approach to this patient, we should always think about and never forget sepsis. You don't want to get MISC vision, and remember the other core mainstays of emergency medicine and critical care. So Sepsis Protocol with careful monitoring of her fluid responsiveness. This patient received 60 cc's per kilogram of normal saline and then became hypotensive and required starting of an epinephrine and norepi drip, and was admitted to our PICU. So over the hospital course, required increasing vasoactive drips. LV dysfunction was confirmed by echocardiogram. Patient was intubated a day into the hospital stay. Developed multiple vessel coronary artery dilatations and aneurysms, which is a very specific finding. And we often, pre-COVID-19 in MISC, we really only saw this in Kawasaki disease. That was kind of the one disease that this was a finding in. But we are seeing this quite commonly in MISC patients. For treatment, she was started on IVIG, aspirin, steroids, and enoxaparin for treatment of presumed MISC. Patient was extubated on hospital day 3. The vasoactive drips were eventually weaned. And hospital day 9, she continued on milrinone for some ongoing cardiac dysfunction, but is continuing to improve. So I just wanted some key highlights about MISC that I think is like really, really important if you're going to take away a few things, is that in this COVID-19 era, we really have to maintain a high index of suspicion for this. However, as mentioned earlier, we don't want to get MISC vision, and please remember to treat for sepsis, broad coverage with antibiotics in these ill patients. It's often indistinguishable early in the hospital course. And this is what I constantly struggle with in the emergency department, is determining, you know, is this looking more like MISC or sepsis? And I really can't tell the difference. There's hints, but we have to go ahead and treat them for both. With these patients, all of them seem to benefit from some degree of fluid resuscitation. However, in our experience, we have to watch very closely for fluid non-responsiveness, signs of cardiac dysfunction very early in the emergency department or the hospital stay. This tends to develop very quickly, often in a couple of hours. So point of care ultrasound is definitely your friend with these patients. I've probably been doing more point of care cardiac ultrasound in the COVID-19 MISC era than I did in the previous 2 years. So, and the last point is consider early consultation and transfer with pediatric referral centers before the patients get ill, further ill and decompensate. There's many, many services that often go into the care of these children, and that almost always is the intensivists, cardiology, infectious disease, hematology, and rheumatology. And a small subset of MIS-C patients may require an ECMO team if their cardiac dysfunction continues to worsen.
I think it's worthwhile for us to kind of review the CDC MIS-C case definition. MIS-C case definition for CDC includes children and young adults who are under the age of 21 who have had fever for more than 24 hours, all have elevated inflammatory markers. This includes CRP, ESR, fibrinogen, procalcitonin, D-dimers, ferritin, IL-6, increased neutrophils, decreased lymphocytes, and low albumin levels, and then multi-system organ dysfunction. They all have some evidence of SARS-CoV-2 infection, whether it's by RT-PCR, serology, antigen testing, or multiple of those tests, and there's no alternative or plausible cause. There's multiple different presenting symptoms, and this is from some case reports on the right side here, where you have systemic, mucocutaneous, respiratory, cardiovascular, GI, renal, and neurologic, as well as musculoskeletal. As far as impact, we've seen about 3,000 cases. So we have 3,742 out of about 3.7 million. So for every case of MIS-C, there's actually 1,000 cases of COVID-19. And we've seen 35 deaths attributed to MIS-C as of May 3rd. And this is all CDC data if people are wondering where this is coming from. And then I just wanted to show this particular graph because it shows the delay in presentation. So if you look at the dotted line, which is like the COVID cases, and then you look at the dark blue line, which is the MIS-C cases, you see that there's a little bit of a time lag. And what we're seeing typically is that patients are presenting anywhere between 2 and 6 weeks after their initial infection, if it's known that if you know the time frame of their infection. And we're also finding some cases in adults. So this is not just purely children. CDC actually published in October of 2020 MISA case series. There were only 16 cases in both the United States and the UK. Most of the patients were young. The oldest patient in this series was actually 50 years old and relatively healthy. Presenting symptoms included fever. 6 of the 16 actually presented for cardiac evaluation, but all had cardiac effect. Many of them had GI manifestations, some with dermatologic manifestations. And what separates this out from acute COVID infection is that the patients actually didn't really have all that many respiratory symptoms. However, they did have evidence of COVID infection with a majority showing ground glass opacities and several with pleural effusions. 10 of the 16 actually required intensive care. Of those, 70% required pressor support. 1 actually required ECMO and subsequently needed both LVAD and RVADs. And then 3 actually required intubation with mechanical ventilation. 2 of these patients died in the series. They were also treated with IVIG, corticosteroids, and IL-6 inhibitor monoclonal antibody. It's I can't really say this. I think it's tocilizumab. Does everyone know how to say that? Tocilizumab. But I think like one of the things that even though that MIS-C is rare in children, we're actually seeing it go beyond the 21-year limit. And so I do feel like for our adult providers, this is we have something to share with our experience with MIS-C and to actually have a high index of suspicion in this era for a similar presentation in adults. I think we can stop there unless people are interested in the rest of this.
Wow, that was really helpful. Thank you both. Excellent presentation. We have a couple of questions in the Q&A. which I thought were really interesting. So we'll start with one that's still open here from Patricia Frost. What is your opinion on why are we seeing a greater percentage of children with COVID? Could the fact that children were rarely tested early on in the pandemic, be a factor here? It's really, I mean, that's one of the things that I've seen in the popular media as well, that children seem to be more affected now, which of course is, I think, part of the interest in the early use authorization of the Pfizer vaccine. What's your impressions, both of you, all of you?
It's probably multifactorial. I'm not entirely sure, but I think children are becoming a larger percentage of the overall vulnerable population that's either doesn't already have immunity or immunity via vaccine. And we are seeing kids going back out into public and starting to socialize a lot more, with schools going back to in-person classes. We're getting a lot of testing referrals for children's centers that actually refer the child for a COVID-19 test. So it could be a combination of the testing being more prevalent in kids now, as Patricia Frost was alluding to.
Is there any change to the variants as they go forward? You know, we talk about the UK variant in the United States or some of the others. Do those have any impact on differential impact on children compared to the, if you will, the native COVID-19?
I don't think that there's enough data for us to really know the impact of the COVID-19 variants at this point. I know here in California, we've actually seen multiple variants that have come through, but most of the data that we've collected is actually from adults. I don't know, Dr. Anderson, if you have any other thoughts on that, but at this point, we don't have enough information.
Yeah, Dr. Lynn, you're exactly right. It's Mike Anderson with HHS ASPR, formerly of RAPM, now on the other side of the coin. It's great to see two terrific RAPM presenters. And I think you're right. There's just, whether it's P1 or B117, I don't think the data is out there. There's certainly no smoking gun that I've seen that P1 affects kids more, or 117 leads to more MISC. But I think it's nice that the nation is thawing and we're getting back to normal. But I do think we've still got to be really diligent around these kids. And the fact that I'm talking, I'm going to take the floor for 2 seconds, if you're okay, Jeff, just to ask a follow-up question. That was a really great presentation. And these kids are just, it's amazing how quickly they go downhill, where you showed it. You give them 60 per kilo of saline and all of a sudden you're reaching for the epi, which is really disconcerting. You also said something that's really important. I've seen great examples like CHLA, like Stanford, where teams really descend upon these kids instantaneously. There's like a big red MISC button somewhere where everybody and their second cousin comes out. The thing that makes me nervous, and I think why ECHO is so important, is that those non-pediatric facilities, a kid with a rash, a little belly pain, but I think we have to take this so seriously. So my question for either my Stanford or CHLA colleague, have we been able to use those terrific EMSC kind of networks to get word out to other emergency departments that network with you that, hey, be on the lookout because these kids can go south very, very quickly?
I think you're bringing up some great points, Dr. Anderson, especially around pediatric readiness and non-peds facilities. And so just a shameless plug out there, there is a thing called the National Pediatric Readiness Project, which is now underway. And it's actually through the EMSC-EIIC. And what they actually end up doing is giving you a score as you assess your pediatric readiness within your emergency department. And this is for lots of emergency departments who basically are not affiliated with major pediatric centers. One of the nice things about this particular project is it provides you with that gap analysis so that you can address those gaps to kind of prepare. So that's aside from COVID-19, but I do think it's really important, and Project Echo is very useful in terms of sending out words like this and other types of preparedness efforts and outreach with a spoken hub model have actually been ongoing. So there's another project called, I think it's the Impacts Project with Mark Auerbach and some of our critical care doctors who actually go out into the community and do some simulation. But I think this is larger than just like a COVID-19 MISC issue and concern, especially for those of us who are in emergency management. It's actually building pediatric readiness and resiliency.
Thank you. There's a few questions in the chat, so I'm going to go ahead and go to those next. Does MISC generally present in kids with predisposing immune disorders or health issues, comorbidities, if you will?
Yeah, I don't think there's currently any evidence to suggest that. For the most part, the kids we see are generally healthy. Of course, we do see kids that have comorbidities and other diagnoses, such as in this case presentation with the history of leukemia. However, no, I don't think there's anything right now to suggest that. We do know from the epidemiology, this does seem to impact patients that are Black or Hispanic background. They seem to make up a larger proportion of the MISC cases.
That was from Cindy Johnson. Appreciate that. Go ahead.
Oh, I would have to agree. The majority of the patients that we've seen here with MISC are actually healthy previously.
And I do think it's important to, highlight when speaking with families and community and providing resources that this is a scary entity. This is a scary diagnosis, but it still is, it is relatively rare. It's a pretty rare occurrence. So I think it's always important when discussing with the community and families that, yes, this is something to be aware of and look out for, but it is thankfully rare.
Following from that, Brad and Anna, do children get similar syndromes that adults get, but milder syndromes besides MISC? What are some of the other things that children may present with?
So most of the COVID cases are pretty mild in general. They actually will present with this similar to adults with cold symptoms. I think we don't actually see a lot of those kids actually in the hospital. The ones that we tend to see, the ones who are really, really ill. We've had a few cases of our adolescent patients being in full-on respiratory failure, so similar to the adults, but their physiology is probably a little bit closer to adults as well because they're older and post-pubertal.
Yeah, I would totally agree with that. The severe cases of COVID-19 we've seen were generally in the older kids and teenagers. Obesity did seem to be a risk factor for needing positive pressure ventilation, at least in my experience here. The other population which it's been a challenge is in actually the neonates and very young infants, because when they present with non-specific symptoms, such as generally in little kids fever, maybe some mild respiratory symptoms, it's indistinguishable from a serious bacterial infection in a very young infant. So often they present irritable and they undergo a workup for serious bacterial infection, including lumbar puncture, and sometimes get admitted for like a 48-hour bacterial rule out.
It was
Thanks, Brad and Anna.
That our first COVID case was actually a 6-month-old who presented with MISC symptoms and was very Kawasaki-like. And that was the very first case that we actually saw back about a year ago.
And Patricia Frost has a question here. For the pre-hospital community, what guidance would you provide?
For COVID?
Emergency medicine,
for
yeah.
For MISC. So for MISC, it's very clear that excellent cardiovascular support is actually translates into better outcome. So we love IVIG, we love corticosteroids, we love our aspirin, we love our anakinra, whatever your pathway happens to be at your local institution. But the mainstay of initial therapy is always address the sepsis or address the hemodynamic instability. And your fluid resuscitation, early pressor support, that is what's actually going to improve the outcomes of these kids when they present.
I'll add for the outpatient community, one theme that really comes forward for me is that the kids that present to the emergency department many times have had multiple visits, either to the same or differing emergency departments or to urgent cares and their primary care physicians. So I personally look for that kind of hint in the history that this is maybe their second, third, or even fourth visit for this febrile illness. And in my experience, that kind of pans out as being a risk factor for something's a little bit atypical about this febrile illness and might deserve more consideration for MISC.
Hey, Jeff, can I do a quick follow-up question on that?
Sure.
So Brad, so let's say I'm a ED doc at facility that sees 15,000 patients a year. And okay, so I don't have a big volume of pediatric patients, but I got some pediatric patients. It's an all-comer thing. So who don't I test for COVID? Okay, so right now I'm thinking, okay, so an orthopedic injury from sports, okay, probably not if that's all it is, but who don't I test? I guess that's more of a, I mean, that's sort of like the approach I'm thinking about right now. So help us with that, because I think there on Rounds, we have a really diverse audience, and I want to make sure we're getting to those that are not tertiary care, level 1 pediatric trauma center, et cetera, and CHOPS, et cetera.
Yeah, that's a great question. So currently, because of the thankful wide availability of testing and supplies now, I offer a COVID test almost to anyone that comes, or if they ask for it, we will provide it. Any patient who I don't have a source for their fever or symptoms, if I look in an ear and I see there's a purulent otitis media, or we have a nice round pneumonia on x-ray, and the patient's well and can go home, I don't push the COVID test. However, any GI symptoms, mild respiratory symptoms, even just vomiting, I will offer in the well-appearing patient that can be discharged a COVID-19 test. One, for epidemiological purposes, and it's going to be important for the family to know for isolation and keeping them away from high-risk individuals while they're undergoing their quarantine. Was that the question? Was that the aim you were going for there?
Rick, why don't we go ahead and go? Oh, go ahead, Anna.
Oh, I was just going to say, I think it's really challenging, but this is where the power of follow-up is really important, right? Like, so you have this one snapshot in time, but ensuring that you have really good return precautions for your patients is important, especially in the setting of quick deterioration. They may look fine to you, but maybe 6 hours later, they won't be so fine.
And I get this one snapshot in time. The number of times I told that to a medical student or resident on a shift, I can't tell you. Okay, so Jeff, I think you were like queuing us up for the polls. And so Anna and there are a number of questions in the QA. If you can, like, while we do the polling, maybe see some of those and answer some of those. So maybe to expedite things for everyone. Samantha, can we do the polls? There's only 3 questions of really straightforward ones. I have sufficient information to be able to identify, and I put diagnose, but then, oh gosh, EMS doesn't diagnose, even though they really do, and that's a whole editorial statement on my own. Able to identify and diagnose a pediatric COVID-19 patient. And Mike Anderson, I'm trying to get a little bit to your, point about like what networks are we using to get some of this information out. So it's that concept. And this question just focuses on diagnosis. All right, let's stop there. 52% voted, 63 of you, I think, voted. Kind of a bell curve, kind of. All right, next. This one's same question with one tweak, and this is treatment, not diagnosis. So Jeff, the challenge with this, in terms of like the polling results, and it's certainly not a randomized controlled trial, but so how many came to this particular round because they have a strong interest in pediatrics versus those that weren't? And I have no idea. There's no easy way to tell that, but I guess I could have done a polling question, but interesting to think about how that influences the results for these. All right, let's stop there. 53% voted, about the same number or percentage. Again, it's very much the same kind of curve, it looks like. Leave that up there for a few seconds so people can see it. All right, thank you. And then the last one. Okay, so this is like the age group. COVID-19 pediatric patients in our organization has seen are most frequently in which of the following age ranges? And then Jeff, after we see these results, I'll turn it back over to you.
Thanks, Rick.
Yeah, I appreciate the input on the polling. I do. It's great. Hey, Bruce, the input on the polling, and I've said it many times on rounds before, is really actually been very helpful in refining these better. But I feel like we ought to crowdsource the polling question development. All right, wait a minute. We got to get this up. It's like 31% vote. Let's keep going for a few seconds anyway. Obviously, I should say obviously, but I should have put in there, I haven't seen any PEDS patients. So, all right, let's stop there. 31% voted, but that's pretty interesting. I don't know if when you take a look at the results, I'm not sure if all of you would have expected those results. I'm not sure I would have. But Jeff, I'm curious, is that, I had no idea what was going to pop up, but is that consistent with what you thought might, or not sure?
I think that my guess is, and this is an adult doctor speaking, the older kids, I think 6 to 11 and 12 to 18 especially, I think are probably, for those of us who are not really taking care of younger kids, probably more likely the age ranges where we're going to be able to identify and recognize this. That's just the adult doctor perspective.
All right, well, let's stop there. Thanks for everybody participating. It's fascinating to see those. Thanks. Over to you, Jeff.
So one thing I would say to our panelists, and I feel very remiss on this, and when I ask people to join us, I don't often always include who our audience tends to be. And we typically at ECHO here, certainly for critical care, we have a lot of EMS and a lot of nursing colleagues that join our rounds. And so I think, again, Rick, those questions, I found them very helpful because I think a lot of our audience is still, I don't know that they're clear in their minds as to what they're looking for with this pediatric illness. And so for both Brad and Anna, Mike as well, and for others, are there any pearls or things, if you're an EMS provider, if you're a nursing provider, not provider, but nursing professional, are there any other pearls that you can provide our community that's here today that might be helpful for them?
Brad, do you want to take this or do you want me to take a stab?
Go for it, and I'll jump in after.
Okay, I think MISC is extremely rare, but if you have a child who has abnormal vital signs, especially tachycardia and hypotension, you really want to kind of stick to the basics of resuscitation. I think that's for our pre-hospital colleagues, that's going to be something that you're used to doing. And the treatment isn't any different in the initial phases for a patient who has MISC versus not. Our nursing colleagues, thank you so much. Last week was, I think, Nurses Week, so happy Nurses Week belated. I think just knowledge is power, right? And having a high index of suspicion is helpful. And don't be afraid to speak out and query as to what possibilities there could be in terms of the patients who are unstable, especially in the setting of the COVID pandemic.
Totally agree. Sorry, getting some feedback. Totally agree. I would say, really listen to the families and the parents of these patients, because like I said earlier, something about these MISC presentations are different than the typical illness. These kids look irritable. They look pan-inflamed. And they can often have neuropsychiatric findings, which are interesting. We've had kids who have been altered, asking repetitive questions or staring like they're having an absence seizure, and other kind of weird, subtle things that, if heard in the history, should raise your index of suspicion. So the families recognize that there's something going on with their kid that's different than the typical illness. And I think sometimes we're quick to dismiss things on history, but this is one case where I really try to listen really, really closely at some of these more subtle things that the family's telling us.
And it looked like Jay had something to add too.
Can you hear me? I'm having trouble with audio.
We can hear you. Maybe just turn down your speaker volume a bit. You should be good.
Sorry, I'm having trouble with audio. I was just going to say that for EMS providers that I just think you have to maintain a low threshold. Our first MISC patient here at Children's of Nevada was basically here for a little bronchospasm. She was 12 years old. She was in fast track. She had a high heart rate. That was her only abnormality, and a little bit of wheeze. And just after she got an MDI, a good nurse, repeated her blood pressure, and her heart rate that was 130 persisted, and her blood pressure was 82/40, and that initiated our shock protocol, and she ended up having the full-fledged MISC. Didn't require intubation, did not require ECMO, but she was extremely subtle and was triaged a level 4 in our triage system initially. So after 30 years of doing this, I have to say this is an entirely new virus, and I take each fever with the utmost caution. So just be careful.
Another good resource, not to plug or sponsor one institution, but they do make their pathways public and easily Googleable. If you just Google CHOP, Children's Hospital of Philadelphia, MISC pathways, publicly available, set up for clinicians. It's not so much for families, but it helps you with the diagnostic workup, because we're really, like most things, we're aiming for very high sensitivity, but at the same time, we do want good specificity. We can't admit every kid with fever to the hospital for an MISC rule out. And it comes into two tiers. Often the first tier is just general screening labs, which include inflammatory markers. And then if abnormal, above certain thresholds or concerning features, kind of a second tier workup, which looks for signs of end organ dysfunction and a few other findings on the lab work.
One of the things we've talked about for the adults in the last several weeks, several sessions, is whether there's, with long haul symptoms or cognitive brain dysfunction from COVID-19. Do either the long-term symptoms or the cognitive dysfunctions affect children to any meaningful degree?
I'm not familiar with any data on that, so I'll say I'm not sure. As far as long-term findings, I can't speak to children with MISC. Often need close follow-up as an outpatient for some time, at least with cardiology and sometimes with other subspecialists. And there have been, I'm sure a lot of people are familiar, there have been the case series and reports of the cardiac edema that's seen on cardiac MRIs after recovering from COVID-19 and MISC. I think still more is needed to know, and of this, more is needed to really know what the significance of that is, because we are now looking very closely at the cardiac tissues after viral illness. Like one thing that always got me thinking was, if we just, in flu season, if we did cardiac MRIs after people recovered from the flu, including children, what would their hearts look like? So that's one thing that we know shows up, at least radiographically. I think we need to know a little bit more about what the significance of it is.
I was going to just chime in that I haven't seen a publication on this, but there is sort of chat room fodder, social media fodder on long haul kids that I've been aware of. And I know of one patient here that's been coming back for 4 to 5 weeks with fever after he met MISC criteria and got IVIG. He just keeps coming back every week with a 104. And I also was reading some literature that there's some similarities at a molecular level with familial Mediterranean fever in some of these kids. So this is falling into that, fever syndrome category that, used to be talked about. We never saw cases, at least here in Nevada, but now we're starting to see them. And I got to say also, just from experience, that this looks an awful lot like Kawasaki to me. I mean, we've been searching for the origin of Kawasaki for 30 years in my career, and it looks an awful lot like it to me. So I won't be surprised if somebody wins a Nobel Prize or something with discovering that some type of COVID virus or variant is responsible for all these Kawasaki's we've been seeing all these years.
I definitely can't take credit for it. It may have been from the Evelina Hospital in London, which was one of the first centers to report MISC, but the term Kawasaki was thrown out there to kind of describe the syndrome, which really does seem to overlap a lot, like Dr. Fisher was saying, with Kawasaki, toxic shock syndrome, and also features of macrophage activation syndrome.
We also have a term Kawasaki for the Kawasaki patients who present with, hypotensive shock.
Any cognitive dysfunction that we've seen in kids similar to what some of the adults have seen? Do any of you have any experience with that?
I've only seen it in the acute phase, like in the emergency department, or just prior to. I don't have any data or experience with post-recovery. I don't know, Dr. Leonard, Dr. Fisher, if you have any information on that.
I don't have any experience with that. I think we did have one patient, a 17-year-old, who presented with stroke and was COVID positive, and we thought that the stroke may have been related to the COVID.
Wow.
There was just a case report of the first one that I'm seeing of idiopathic intracranial hypertension with COVID-19 published in American Journal of Emergency Medicine. We see that with roseola sometimes. These kids that look pretty well have bulging fontanelles, and we think their arachnoid villi don't work quite right for a period of time. And that was just reported in American Journal of Emergency Medicine with COVID for the first time. So this virus, like all these nasty viruses, get into every tissue and cause every problem. So I think we'll see every permutation of this coming down the line.
Thank you, Dr. Fisher. One question that was in the chat session regarding vaccines and which vaccine. There's only one vaccine that's available in the United States right now to children. That's the Pfizer vaccine. Are there any other things coming down the pipe? Will the others, do you think, be licensed for pediatric age patients? And do you have any sense, and you may not have any information on this, on when, kids below the age of 12 will be able to be vaccinated? So I'll just ask for any insights or thoughts that all of you have there.
Correct. You are correct in that Pfizer is currently the only vaccine that actually has EUA for 12 to 15 at this point. I think Moderna will be close on its heels. They do have some data that is suggested that they are as effective and as safe as the adult data that is out there at this point. Pfizer is conducting phase 1, 2, and 3 trials in children as young as 6 months at this age. And we do expect that patients older than 2 should be able to get vaccinated later this year. The hope would be that we would be able to start vaccination in September, October of this year for the younger age group down to 2 years of age. But again, that's hopeful, and we'll have to see. But so far the data looks really, really good in terms of efficacy. I think there were 2,200 patients that were enrolled in the Pfizer study. And like of those who were vaccinated, none of them actually got natural disease at all. And the safety profile has been really, really good as well.
Yeah, I was going to say I was wrong in the chat. I put Pfizer and J&J here in Vegas, but no, I was wrong. We are just using Pfizer in 12 and up, so I apologize for that.
Rick, I think we're right at the top of the hour here. So if there are any last thoughts that you have, I'll go ahead and turn it back to you. I also want to thank both Brad and Anna for being here, as well as all our panelists, Jay and Mike Anderson. Wonderful discussion. Thank you all. I learned a great deal, as I always do, from all of you. Thank you.
Yeah, thanks, Jeff. Hey, Jeff, number one, really appreciate your putting this on the critical care schedule. This, we started, the very first one we did on pediatrics was with our colleagues from the UK when it was first starting to pop in the media, actually in the media before we saw even papers on it. And then, over time we've done a few, but Jeff, it strikes me we still have, we're nowhere close to being done with the pediatric challenges, especially as I think reflect about schools opening and how that's going to impact all of this. Lots of unknowns ahead. So thank you again for doing this. Echo, thanks as always. Great. To our participants today, especially the chat, and not just the chat, but Anna and Brad, especially appreciate your jumping on the questions that were in the QA. It's been, and that plus then the case presentation, Bruce and I were texting back and forth. We haven't done a case presentation, had one in a while. and it kind of like reminds us, like there's some things around long haul we'd like to do case presentations around, and then the mental health of clinicians that we need to stay. I mean, there's a lot. Yeah, after 155 or 60, whatever we got a long haul for rounds to go for sure. You know, when we do reach out to individuals to help us with participation, either as presenters or panelists, please help us, because it really helps us do the best we can for the greater good indeed. So with that, again, thanks to our panelists and to our speakers, really just extraordinarily, it's like one of those sessions where it's like you walk away and say, wow, I really learned a lot. And that doesn't always happen on rounds, but this one in particular. So thanks all. And before you leave, reminder, tomorrow, and I don't remember the exact wording of it, but it's like how the pandemic has changed crisis standards of care. And I know some of you who are on rounds right now have had that experience. And so probably worth helping us sort that one out some. And then actually the two presenters are going to be the lead authors of the original National Academies of Medicine report way before the pandemic, Dr. Hamfling and Dr. Hick. And then next Monday, and I know it's one of the things we're trying to do, just for everybody's awareness, we're trying to make it so that for some of the grand rounds that are interdisciplinary, I'm not going to have it on always the same day of the week, because sometimes, like we're doing Monday next week, which is usually EMS rounds, but we're trying, and Jeff has really helped out with this a lot, doing the interdisciplinary thing. So that one's going to be on why are so many hospitals and EMS organizations unprepared for another surge. I've got some ideas, but I'm going to have to learn just like you are. So with that, thanks all, and we'll see you on the next one. Bye.
Bye, everybody. Stay safe.